Dear students, welcome with the INICET your ENT discussion. The first MCQ, again a repeated MCQ taken from your last 2 years question bank. Which of the following is a true sequence of auditory pathway beta? So if you remember in objective audiometry, when we discussed the investigation of choice for neural deafness, that is your brainstem evoke response audiometry, we have learned the sequence. What is the sequence of auditory pathway? We always learn this mnemonic ECOLIMA. So that is your 8 now, followed by cochlear nucleus, followed by olivary nucleus, lateral lemniscus, inferior colliculus, medial geniculate body, and auditory cortex. So these are the important 7 landmarks. Out of these, the first 5 landmark, what is the investigation of choice? Investigation of choice is brainstem evoke response audiometry, and for the higher centers we are going for cortical evoke response audiometry. That is a big drawback of brainstem beta, okay, we cannot diagnose the higher cortical centers. Now coming on the true sequence, the first one is your 8 now. The option 8 now is not there. Next option is cochlear nucleus beta, one of the easiest MCQ. Cochlear nucleus followed by olivary complex, lateral lemniscus, inferior colliculus. Clear? So the answer will be the B option. Now let us discuss with the other options. Superior olivary complex. What is the importance of this superior olivary complex? Is the highest center for stapedial reflux. So in your next upcoming INICET, they can ask you which is the highest center for stapedial reflux. The answer will be superior olivary complex. One important point. Then on the beta, always remember beta, we are having 7 waves, and what is the concept? The first 2 waves are for the 8 now, and the last 2 waves are for the inferior colliculus, and rest all are having one wave each. Clear? And which is the largest wave? Always remember the golden rule, lateral lemniscus, L for lateral, L for largest wave on the beta. Clear? So this is one of the important simple MCQs of audiometry. Coming on the next one, this is what I have taught you. This is auditory pathway 8 now, cochlear nucleus, superior olivary, lateral lemniscus, inferior colliculus, and followed by medial geniculate body. I hope very simple, straightforward. Question number 2, my favorite question, CA larynx. And if you remember, we have revised classification, TNM classification of the CA larynx in the class more than 3 to 4 times. But instead of asking the MCQ TNM classification by giving a CT finding or MRI finding or all the other DL examination, examiner have given you a slide integrated MCQ of ENT with radiology. Now just first of all, before going in the CT slide, just try to appreciate what is a golden rule of TNM classification. T part we have read in the classroom. One is here T1, that is a tumor is confined to the larynx. T2, tumor is confined to the larynx, but difference is one area is involved. If we go in the favor of T1 or 2 is T2. What is T3? T3 is your tumor which is invading your larynx surrounding areas like paraglottic space, like pre-epiglottic space, like pharynx. These are the important areas which, if involved, we go in the favor of T3. And what is T4A and T4B? T4A is the involvement of muscles attached with the thyroid cartilage. If the thyroid cartilage is invaded, all the neck muscles, which neck muscles? Sternothyroid, inferior constrictor, or your thyroid muscles, these muscles are involved. Even if your trachea is involved, we go in the favor of T4A. Am I understandable? So what is being shown in this image? The tumor is invading the thyroid cartilage. Am I understandable? Are you getting this point? Is going outside the thyroid cartilage, is invading all the surrounding structures, muscles attached with the thyroid cartilage. So what will be the best option? Among these, the option will be your D option, T4 and 1 and 2. Am I understandable? Clear? And T4B, what is T4B? T4B is the involvement of your T4B will be involvement of mediastinum, carotid artery, prevertebral space. If carotid artery is there, prevertebral space is involved, or your mediastinum is involved, we go in the favor of T4B. What is the golden rule of management with a T1, T2 single modality? I will be going for single modality radiotherapy, or I will be going for partial angiectomy. We rarely do these partial angiectomy. Quality of life is very much compromised. Therefore, we prefer radiotherapy over partial angiectomy. Always remember this point. What about T3, T4? One of the simplest topic where the MCQ answer is always total laryngectomy. Here we are going with total laryngectomy with radiotherapy. And if the patient if the patient is not interested for the surgery, then what is the next step we can go for is here concurrent chemoradiation. We can go for concurrent chemoradiation. So this is an important rule, concurrent chemoradiation, but only if the patient deny for the surgery. So this is a management part which should be on your tips. So answer question number 2, answer will be here D option, CA larynx. And again, better this INICET have proved that importance of revision part. If you have revised TNM classification 3 to 4 times directly, you can hit this MCQ, the thyroid invasion, going in the favor of T4 and 1 MQ. I'm understandable, clear. Coming on the next one, comment on the grade of retracted man. This is again a difficult MCQ. Why? Because examiner have given you the orthoscopic finding. First of all, let us go again back in the class notes. What we have written in the for flaccida, we are using the TOS classification. For part tensor, we use SEDE classification. First of all, just remember this. Now, SEDE classification, where we are explaining the retraction of part tensor, one thing is damn sure: when the part tensor is retracted, your reliable markers will be absent, cone of light and all those structure will be absent. I'll be discussing the SEDE classification with you, but in this cone of light is visible to you, so somewhere the retraction is more in the par flaccida segment. It means I will be going for TOS classification. It is in the upper part. So we have 4 grades are there. In grade 1, just remember now, the simple rule, what is grade 1 is par flaccida retracted but not touching malleus, and grade 2 is touching malleus, which we can appreciate on orthoscopic finding. How can you differentiate grade 1 from grade 2? This was a query of most of the students. Okay, sir, on orthoscopic, how can you differentiate? But if only malleus visible, only shadow of malleus is visible, that will be grade 1. But if the tympanic membrane par flaccida is retracted to such an extent that it is touching the whole malleus, obviously you will be getting some reflection. Some part of the middle ear like incus or the short process of incus may be visible to you, or other important landmarks in the middle ear may be visible. So what we always teach, okay, if your malleus is visible and there is only a dimple, there is only a dip at par flaccida, we call it as grade 1. But if more than malleus structures are visible to you, somewhere some short process of incus or any other landmark, we go for grade 2. Again, better revise with me. If par flaccida retracted and only malleus visible to me, visible, not touching, but visible to me, I'll go for grade 1. And if along with that some other structure landmarks are visible, I'll be going for grade 2. Grade 3, grade 4. What is grade 3, grade 4? Grade 3 is your mild damage to epitympanum. Grade 4 is severe damage to epitympanum. We'll be going for all the radiological investigations, or we can go for here other invasive investigation to appreciate the damage to epitympanum. Grade 3, grade 4, we can't differentiate on orthoscopic examination. I hope you're getting my point. So there is no evidence of damage in the upper part. So it will be not grade 3, grade 4. It will be either grade 1 or grade 2. And how to differentiate, I have explained you nicely. So revise with me with a TOS classification. Grade 1, retracted but not touching malleus. Grade 2, touching malleus. Grade 3, mild damage to epitympanum. Grade 4, severe damage to epitympanum. And what is SEDE classification? Again, grade 1, it is retracted. Which part? Part tensor are retracted but not touching incus. Now here will be reference point incus. In TOS classification, reference point was malleus. Here is incus. Retracted, not touching incus. Grade 2, touching incus. Grade 3, it is retracted so much it is touching promontory. But how it is different from grade 4? In grade 3, it is mobile, but grade 4, it is adherent to promontory. Therefore, we use the word atelectasis of ear for the grade 3 and adhesive ear for grade 4. Examiner was asking you par flaccida because the cone of light, the lower part seems to be normal. So I will be going in the favor of TOS classification, and that will be your grade 1 because no other landmarks visible, only a dip visible at par flaccida. So answer will be your grade 1. Clear? Coming on this is again, I'm showing you the cone of light is there, retraction, there is some retraction in the par flaccida, there is some depression on the par flaccida where I can appreciate a malleus, so it will be grade 1. Okay. Coming on question number 4, a 40-year-old patient coming in the emergency with vertigo, dizziness, or very nice MCQ, nicely formatted. It was an integrated question of ENT, opthal, medicine. So let us crack this question. What should be the approach to this MCQ? Again, I appreciate the examiner by he have given a word keyword horizontal nystagmus. If you open your notes, we have just highlight this point. Lateral cannot have horizontal nystagmus. Just the golden rule which we follow. Okay, is your superior cannot if involved, it will be rotatory. It will be rotatory. If your posterior canal is involved, is vertical. And if the horizontal canal, lateral canal, it will be horizontal. So the word horizontal is ruling out two choices, beta. Which choice? Superior and posterior. This should be the approach to the MCQ. So I can rule out option A and B very comfortably. Now coming on the option C and option D, it is right hypoactive or left hypoactive. There is one rule, beta, which we have to just, this is a concept which we have to remember, and I give a mnemonic to you now. Just listen. S. I understand what is this one. What is the mnemonic of SSS? The slow component of nystagmus. Slow component of nystagmus is on the same side. In slow labyrinth. I hope you will never forget. The slow component of the nystagmus will be on the same side of slow functioning labyrinth. Slow walking, slow functioning nystagmus means hyper or hypo. Sir, hypo. I hope you are getting my mnemonic. The rule is, what is the golden rule you have to memorize? The slow component of nystagmus is to the same side of a hypoactive labyrinth. So now here it is on the left side. So in hypoactive, that is slow functioning labyrinth, it is on the same side. So left means left is hypoactive. I hope you understand how to crack these MCQs better. So the golden rule which you have to memorize in unilateral vestibular hypofunction, beta, this is an important rule. The slow component will be to the same side of the lesion, and quick will be toward the opposite side. This is an important rule which you have to follow. I am sharing this table which you must have revised multiple times. The difference between the peripheral, which is very severe, it show the phenomena of fatigability. There can be associated symptom of hearing loss. When you ask the patient to close the eyes, these symptoms will worse. But in case of central causes of nystagmus, they will be better. Am I understandable? The nystagmus is more of horizontal. Clear? So these are the important point, how we differentiate peripheral nystagmus from the, everybody knows this table is one of the most important often repeated MCQs from this table. Clear? But why? What is the way to crack this question? Is a rule. Slow component of the nystagmus is to the same side of hypoactive labyrinth. This is a rule you should memorize. So these were the important points in ENT segment, beta. Just focus the strong message after this INICET examination. We have to focus on revision segment, beta. This is a very crucial year of your life where you are preparing for your post-graduation, and take my word, beta, try to learn the rule of this game. We have to handle 19 subjects and we have to revise multiple times, beta. So very friendly advice, being a medico, I'm giving you. Focus on the revision part, concise your notes, revise them properly again and again. Thanks a lot for listening to me.